Suzanne. Yes, I'd like to welcome everyone. They are outside a site or people who can join the talk. I'd like to introduce Dr. Kaczorowski, who is a PhD professor and research director. He's from the Department of Family and Emergency Medicine at l'Université de Montréal. He's also professor and research director of the Dr. Sadak Besrour Chair in Family Medicine, and also the GSK Chair in Optimal Management of Chronic Disease, CIHR, okay, and okay, from the Institute of Circulatory and Respiratory Health. He's also a co-director of the Health Innovation and Evaluation Hub. He's going to talk today and present about the pragmatic cluster randomized trial of the Cardiovascular Health Awareness Program, the CHAP, for social housing resident in Ontario and Quebec, Canada. I would like to welcome you. Thanks.
Well, thank you very much. It's really a pleasure to be here, and thank you very much for inviting me. Thank you very much for the introduction. I'm going to talk about this trial, but I'm going to give you a little bit of a background as to how this sort of program came about, what it is all about, and what we try to accomplish with this program. So again, for I guess most of you, this is no big surprise. We know that we really have a problem in terms of modifiable risk factors, which are really the main driver of not just cardiovascular disease, but a whole cluster of chronic conditions. It's really about obesity, hypertension, diabetes. At the same time, our population is aging. I think that even well-resourced countries such as Canada are really beginning to face challenges in terms of how to address aging population, comorbidity, the fact that our population tends to live longer. And contrary to what we have hoped for, we don't have a lot of compression of morbidity. You know, there was this idea a few years ago that people would maintain very healthy lifestyle, would have no comorbidities, and then they would suddenly die after 2 or 3 months of chronic disease. In fact, if we look at statistics, that's not the case at all. So despite the fact that life expectancy has improved, the years of healthy living have also increased. So basically, we have more and more people living longer, but living longer with a lot of comorbidity. And a lot of that comorbidity is cardiovascular in nature. We also know that a lot of both morbidity and mortality associated with cardiovascular disease is preventable. And that's, of course, a big challenge. We know what are the main drivers. We know that it's really about sort of the big five modifiable risk factors. It's about our level of physical activity. It is about our diet, nutrition. It is about smoking, alcohol. Those are sort of the main drivers. We know that if we were to address those modifiable risk factors, we would significantly improve the health of our population. But as we all know, in practice, this is actually quite challenging. It's difficult to change lifestyle. People tend to be comfortable with what they do. Takes sort of a lot of effort to suddenly become physically active or make sort of major changes with respect to lifestyle. So a few years back, myself and a few colleagues at that time I was at McMaster, we really sort of started to look at, can we actually develop sort of a program that would help to address some of those issues. Really sort of the goal of shifting the distribution of risk. So, if we could sort of shift it a little bit, that would actually have fairly significant impact on the overall health of the population. And one of the challenge was also how to integrate sort of both the individual and population level strategy. So our system is fairly good in terms of going after individual level risk, but we tend to focus on sort of the tail of the distribution, whereas most of the events actually tend to happen more in the middle of the distribution. So populational strategies tend to be much more effective in terms of the actual impact on reduced morbidity and mortality. I guess another sort of striking thing about Canada, and I've worked in Ontario, in Quebec, and in BC, is that we are actually very fortunate. We are very well resourced. There is a lot of programs, there is a lot of agencies, there is a lot of initiatives. Unfortunately, most of them are very poorly integrated and coordinated. So a lot of times, really good programs are underutilized or utilized by the patients who would actually benefit the least, and the people who would really benefit from them are unfortunately not part of it. So for me, sort of the big issue in our system is really coordination and integration. And I guess reform after reform attempts to address that issue, but to be perfectly honest, even in Quebec, supposedly we have the Ministry of Health and Social Services, which is unusual because both of them are under the same umbrella. And despite that, there is still incredible silo between sort of social services and sort of programs geared at prevention and so forth, and health services. So it's a real challenge because there are incredible synergies in terms of what could be done if we were a little bit better in terms of sort of making sure that the right program is delivered to the right person at the right time and in the right setting. So really sort of more organizational challenge than the challenge of not knowing how to do it or not having the resources to do it. And we're also very, very sort of interested in looking at things which are fairly inexpensive, pragmatic, fairly easy to implement. I think that it is very easy sort of to develop a new program that's going to be very expensive and is going to improve outcomes. I think that the challenge is how do you develop a program that either is delivered at the same cost, or better still, at the same cost gets better results. And a lot of programs that we see, they are wonderful. Obviously, they are not scalable. I'm looking at some of the programs in rehab and those kinds of things, and they are wonderful. But those are packets of excellence. They are not scalable. They are not sustainable. So the end result is that, yes, the few people who happen to be participating in these programs benefit a lot, but the impact on the overall health of the population tends to be fairly marginal. And then, one of the sort of big challenges, and I've been always in family medicine, is that a lot of things that happen at the level of public health, at the level of prevention, at the level of different programs around lifestyle issues are not linked back to primary care. So in a sense, a lot of sort of good things happen, but again, they are not coordinated. Family physicians are not back in the loop in terms of initiating therapy, supporting lifestyle changes, and so forth. So again, the big sort of starting point for us was, how can we sort of close that loop? So we have a linkage between what's happening in the community and what's happening in primary care. And I think that, again, those are some of the guiding principles of the program itself. That a lot of people talk about sustainability and scalability, but I think that those are sort of the building blocks of sustainability and scalability. In order for a program to be sustained, well, first of all, it has to be effective. There's no point of sustaining programs which are not effective. And clearly, a program that is sustained is much more likely to be scaled up. But again, the starting point is that if you start developing Rolls-Royce type interventions, the likelihood that any of that is going to happen is quite unlikely, because despite the fact that we do have quite a bit resources, we don't have enough resources to provide one-on-one coaching, to provide sort of 24-hour care or very personalized support for individuals. So I think that finding that sort of sweet spot between something that's effective but also implementable and sustainable was one of the guiding principles. And we've done sort of a fair bit of work just sort of figuring out different aspects of how the program ought to look like. So starting with very sort of a small pilot project involving one pharmacy and one family practice. Then we did another one with a pharmacist and a couple of local volunteer organizations. Then we sort of moved on to a community demonstration. So we were wondered to see if we could implement the program at a community level. So we did demonstration projects in 2 communities of 25,000 individuals in Ontario. And then we were sort of reasonably certain that perhaps we had a model that we could rigorously evaluate using a randomized control trial methodology. And sort of that was the trial that we designed and put in place. The CHAP intervention was really about sort of creating a community program that would take advantage of the existing resources and really sort of raise the bar in terms of awareness, in terms of what people know about the risk factors and so forth, but also linking them with community resources and also linking them back to family physicians. So if proper diagnosis was needed, if initiation or titration of medication was needed, the family physician was in the loop and he or she would be able to react. So a couple of sort of interesting features of the program was that we are probably one of the first groups in Canada that started to use automated blood pressure measurements. So at that time, BP True was probably the only device that was able to do that. I don't know how many of you are familiar with automated office blood pressure measurements?
Is that what you find in pharmacies?
No.
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 So what is the automated device that are in the pharmacies?
No, you see, the automated device, like the one that we are talking about here, so BP True would take 6 consecutive readings, either at 1 or 2 minute interval, discard the first reading and average the remaining 5. And by doing so, you're actually getting a fairly accurate and valid assessment of blood pressure. So actually, if you look at the consecutive readings, the first one tends to be quite high. You have a fairly significant drop to the second one of around 15 millimeters. The third one is probably another 5 millimeters lower, and then the remaining ones tend to plateau. And if
All the blood pressure machines that you see in Jean Coutu,
you know,
what are they?
they are better than they used to be. So I can tell you that we've originally, when we designed the program, we thought, why not take advantage of those BP machines in the pharmacies? And then we started to sort of look at how accurate and valid they are. And at least at that time, turned out that essentially there were devices mainly for the purposes of marketing. So someone did a study that if there is a BP device in the pharmacy, the people on average would spend $1.15 more, okay? And that was utilized sort of as sort of the basis for marketing. And we look at sort of maintenance and how they are being maintained and all that. Terrible. I know that now they have changed quite a bit, and I work with one of the distributors, with PharmaSmart, which is sort of the big distributor of those devices. And now they went through the validation, so they're validating those devices. They've done a lot of work in terms of improving the CAF, The big problem, of course, is that you have sort of one size fits all. So you have to be really, quite smart in terms of how you do it. So nowadays they are much more sophisticated than they used to be. But when we were sort of starting our work, the reason why we started to use our own devices because we were just not comfortable that information from pharmacy was really accurate. And part of the issue was, selling this information to family physicians. So if you're going to give feedback to family physicians that, your patient's elevated blood pressure, they have to trust that the way that we measure the blood pressure and the devices that we use, that they are valid and appropriate. So our volunteers would undergo training in terms of how to properly assess blood pressure. So we had 4 different cuff sizes, so they would select appropriate cuff size, and then they would follow the Hypertension Canada guidelines with respect to, not talking, both feet on the ground, consecutive readings, and on the basis of that, we were able sort of to provide family physicians with accurate information. We would also collect self-reported risk factors with respect to both the history and previous diagnosis. So we would ask people about their diet, physical activity, but it was essentially a one-page sort of risk factor assessment. And then based on assessment and interest, we would provide educational information and we would link participants with programs and resources that existed in their communities. So say someone was not very physically active, but interested in becoming more physically active, our volunteers would have a list of programs in their community that walking clubs, YMCA, and so forth, that they could go and initiate some of those activities. And we also had community health nurse and a pharmacist for reassessment. So the protocol was that if someone's blood pressure was higher than 180 systolic, that person would be reassessed by a pharmacist or by a nurse, basically to take proper history, to remeasure blood pressure, and then take appropriate action. For people who were between 160 and 180, we would ask them, please return for another session, and we'll reassess your blood pressure if it's okay or not. And then depending on the results, again, either we would refer them to their family physician or to different programs depending on the results. And just to explain you the program a little bit better, is it me? Yeah, ready.
There are over 7.5 million Canadians who have hypertension and another 7.4 million who have high blood pressure that will lead to a hypertension diagnosis if actions are not taken. John has high blood pressure, but he doesn't know it. Just like more than 1 million other Canadians, he feels fine. At John's local pharmacy, a new program has started, the Cardiovascular Health Awareness Program, CHAP. John answers several questions to see if he may be at risk for cardiovascular disease and diabetes. And carefully trained volunteers help him take his blood pressure using an automatic blood pressure monitor. John gets his results and is very surprised to see his blood pressure is higher than it should be. With John's permission, John's physician and pharmacist get his risk profile and blood pressure reading. John's physician remeasures his blood pressure, and together they develop a treatment plan that includes lifestyle changes and going back to CHAP sessions regularly. John's friend Priyanka has high blood pressure which is difficult to control, even with her medication. She attends CHAP regularly at her local senior center. Through CHAP, John and Priyanka learn about resources and community programs that help to reduce high blood pressure. They are both reassured to know that their physician will be notified if they ever have very high blood pressure. Priyanka and John's respective physicians and pharmacists know that accurate blood pressure readings taken out of the doctor's office can help with diagnosis and ongoing treatment. CHAP sessions use blood pressure monitors approved by Hypertension Canada, and blood pressure is measured following the latest Canadian guidelines. John's high blood pressure is detected and treated. Now, Priyanka and John both have well-controlled blood pressure. They are both actively working towards lowering their risk for cardiovascular disease and diabetes, including heart attack and stroke. Based on 20 years of research evidence, CHAP is an internationally recognized, award-winning program that improves people's heart health without additional healthcare costs. Learn more about how your community can implement CHAP at www.chapprogram.ca.
So this is sort of, in the nutshell, sort of the promotional video of what we've been doing. Now I guess I'm going to tell you a little bit more about the program and some of the results of the program and where we are now with the program. So this probably is familiar to most of you. So this is the famous extended chronic disease management model by Wagner. And what we did, we sort of plotted the elements of CHAP on the model. So it's really about activating the patient, activating healthcare provider, working at the community level, integrating different resources. So again, with the expectation that if you have this more holistic and coordinated approach to care, you are much more likely to have impact with respect to cardiovascular disease. The sort of big trial that we did was really to see if a program like this implemented at the population level can actually make a dent with respect to objective measurable outcomes. So we were really focusing on reduction in cardiovascular admissions to hospital at the community level, and our primary endpoint was administrative databases. So we actually implemented the program at the community level, and our denominator was the total population 65 plus in intervention communities, regardless of whether they participated in the program or not, compared to control communities, again, people 65 plus as our control group. And it was a community RCT, and this was done in Ontario, so our inclusion criteria sort of at the community level was that we targeted communities of between 10 to 60,000 individuals, communities that had at least 5 family physicians, at least 2 pharmacies, and we were focusing on population 65 plus that was community dwelling. So we are not looking at institutionalized individuals. And we had a couple of exclusion criteria. So these are the places where we did some of our pilot work. And in fact, when we did this study, there were only 39 communities that met that inclusion criteria in Ontario, based on size and our definitions. And we created 7 different strata based on geography, proximity to urban centers and so forth, and basically we randomized them into 20 communities that would receive intervention and 19 that would be our controls. And the sessions were held in the local pharmacies, and they were supervised, or patients or participants were assisted by trained volunteers, and we had a nurse or a pharmacist who was sort of there in case we identified people who had very high blood pressure, people who sort of really required more proper assessment. So in terms of implementation itself, I think we are fairly successful.
I'm sorry. There were 39 communities, right?
Yeah, but 19 are controls. We did nothing in controls.
How did you get the approval of the communities to participate in this trial?
We did not.
Oh, you didn't? Okay.
We didn't, because we were relying on administrative databases. So the people who attended the sessions, they would send the consent, they would sign the consent form, that the information could be shared with their family physicians and so forth. And then in terms of analyzing, we really look at totality of population 65 plus in control communities and the intervention communities. So we didn't need approval to do so. And we simply looked at admissions to hospital before and after the program, comparing intervention to control communities.
You know, I'm surprised about that, just because you're taking blood pressure
Mhm.
readings from individuals in your
Mhm.
intervention community.
Mhm.
So provide consent. Pardon me? Those who participate provide consent. Okay. So why couldn't you do that in control communities too?
By what? But because our outcome was not reduction in blood pressure, our outcomes was reduction in hospitalizations for cardiovascular disease. So our interest was, again, that the logic is that if we can reduce blood pressure, if we can initiate more people on therapy, if we can, if people can make changes with respect to lifestyle, adherence to medication, that would subsequently translate into fewer heart attacks, fewer strokes, and so forth at the population level. So that was sort of the logic behind it. And another aspect of it, for me, this is how pragmatic trials ought to be done. That you really sort of reducing or eliminating as much as possible sort of the data collection, you relying as much as possible on existing information. So people really participate in the program as opposed to in the research project. And I think that that was sort of, again, the logic behind our design.
You plan to look, and this is very interesting as a design. It's quite creative, okay, with real world evidence.
577 volunteers.
Yeah.
Yeah, that's also very interesting. Okay.
Yeah.
It's
So
really taking advantage of the whole chronic care model from the community. But did you compare? Do you have anything? Obviously, your outcome is health administrative database. Did you have anything that allowed you to say that these community were comparable to the
Oh, yeah.
you have in the control intervention?
Oh, absolutely. I'm going to show you the data. Yeah, so the way that we have done it, we sort of look at our inclusion-exclusion criteria. On the basis of that, we had an outside expert in cluster RCTs. It was actually Alan Donner from Western, who he did sort of the random allocation for us. And then we knew that we had 20 intervention communities. We went to those 20 intervention communities and we said, there is this wonderful program coming to your community. Are there any local organizations that are interested to work with us, organizations that have interest in health and experience with volunteers? So we partnered with 20 different organizations. Some of them were local hospitals, Meals on Wheels, VON, so different organizations, different communities, and they helped us to recruit the volunteers. So 577 volunteers, because basically for 20 communities that is around 30 volunteers per community that we needed. The program ran only for 12 weeks, so it was fairly intensive, 12 weeks of those sessions. So you see, in total, over that 12-week period, we held 1,200 sessions in the local pharmacies, and virtually all the pharmacies have participated. So 145 in total, of those 129 participated. And really the only reason not all of them participated, because some of them didn't have enough space, some of them were not open sort of during the hours that we wanted to do it. Once you get one pharmacy in the community, all the others want to participate, because they're afraid that they're going to lose out in terms of how they are seen by community members. So you have to sort of use a little bit of that kind of strategy to get people on board. We also got almost over 24,000 letters that were sent by family physicians. So we approached all the family physicians and we said, look, there is a program coming, we're going to do it. It would be great if you are part of it. If you are interested, we're going to assist you in generating invitation letters to all your patients over 65. And basically 214 of them said, yes, let's do that, okay? And we generated those letters and sent personalized letters to their patients on behalf of the family physicians, basically saying, look, there is this program coming, I'm part of the program, I think it would be a good idea if you go and participate, and I'm going to receive results of that assessment. And over that 12-week period, we conducted assessments on 27,000 individuals, 65 plus, and of those, almost 16,000 were unique, because we had this protocol that some people were asked to return for additional assessments, which basically represented around 25% population 65 plus in those communities. We published the results in BMJ. And you are asking about sort of the comparison of the communities. So this is, again, exclusively based on administrative databases. So again, we are focusing on patients 65 plus. So on average, close to 4,000 individuals, because again, communities ranging from 10,000 to 60,000. In terms of age and everything else, basically, there are no sort of meaningful differences between the groups. They are very comparable. I guess the only one is probably in terms of size, because I think we had two larger cities and they ended up in the in the control group. But that was just due to chance alone, okay? Because we had a couple of communities that were 50 and 55,000, and both of them ended up in the control group. And these are sort of the main results. So our main result was really the composite of admissions for stroke, CHF, and MIs. And this is sort of our denominator, which is total population 65 plus in the intervention and in the control community. So around 70,000 people in control and in the intervention. And you can see that in the controls, their rate was 29, and it went slightly higher. And in the intervention, it actually reduced by around 9%, which corresponds to around 3 fewer admissions per 1,000 people 65 plus. And we had significant difference with respect to MIs and to CHF, but surprisingly not for stroke. And some of the secondary outcomes which sort of probably explain what happened, this is probably the most important, fairly significant, again, at the population level, change in terms of initiation of hypertensive treatment. And again, this is done through administrative databases, so looking at the full population. We were looking at new prescriptions for antihypertensive medication for people 65 plus, and we had sort of 10% increase in the intervention communities compared to the control communities. So that was, like very sort of exciting, but people were criticizing us and saying, well, so you showed that you could do it in small to medium towns. Can you do it in large urban centers? Can you do it for different ethnic groups? Can you do it for younger individuals? And so forth. So we sort of started to actually tackle some of those. And the one that I'm going to talk about today is sort of the study that we have just completed for residents in social housing and in Quebec and in Ontario. And this is sort of a little bit of our vision. So this is where we started. And then we figured those are some of the knowledge gaps. Those are some of the studies that we need to do in order to demonstrate that a program like this could be also utilized for different types of conditions, for different types of settings, for different size of populations. And individuals living in subsidized housing is an interesting group for a number of reasons, because by definition they are of considerably lower socioeconomic status. Because in order to be eligible for social housing, you have to have low income. That also tends to correlate quite heavily with variety of lifestyle issues. So you have a clustering of sort of unhealthy behaviors and so forth. And of course, another nice thing is that it's a captive audience because they all live in one building. And by and large, based on a variety of different data sources, the prevalence, the burden of disease tends to be higher for comparable age groups for individuals who live in social housing compared to everybody else. And fairly significant proportion of individuals living alone, which on its own is probably a fairly significant risk factor for a variety of conditions. So somewhat sort of similar design. This time we decided to randomize buildings. So we decided that we would sort of look at buildings, and again utilizing administrative databases. So I think that we always like this idea of sort of reducing the burden of data collection and really sort of delivering the program rather than doing a research project and collecting tons of data. And we focus on a reduction in unplanned CVD-related Emergency Department or CVD hospital admissions. And again, it's a cluster RCT. So we had social housing buildings on the South Shore. So we were working with Social Housing Authority in Longueuil. And our colleagues from McMaster were working with social housing in Niagara region, so that's wine country. We, as inclusion criteria, focused on buildings that had at least 50 units. So we didn't want to sort of to go for smaller units. This is sort of another trick that we did this time. So once your building gets that big, frequently you have your own unique postal code. In fact, if you're looking at some really big towers in Montreal, some of them would have multiple postal codes because the building is so big. But we sort of figured that, again, for the purposes of accessing data, we would focus on buildings which are large enough to have a unique postal code, 6 digits. So that's, you know, basically fairly good. And there are buildings both in Ontario and in Quebec that cater specifically to seniors. There are social housing buildings that cater to families, but there are also buildings that cater to seniors. So we focus on buildings that are majority seniors. And for the purposes of social housing in Quebec, that means that you are 55 or over. And we match our buildings in terms of resources, geography, demographic characteristics, and then we randomly allocated them into control and intervention. And we've done some pilot work in 4 of the buildings, so we've excluded those from our from our study. Well, this is sort of, you know, one of those complicated consort figures, but basically it shows you sort of how we went about allocating our buildings. And again, we did nothing in the control buildings. So the control buildings, they didn't even know there is a study. They were never approached to do anything. They were just there. And we did publish sort of the design of the of the study actually in December of last year. The intervention was a little bit different. So, you know, part of the reason why we sort of decided sort of to do more of an outreach program, because we started to notice that participation in sort of CHAP sessions in the pharmacies or somewhere else started to decline over time. And it's sort of, I have sort of a number of hypotheses why that happened, but it seems that when we started the program, it was not unusual to get 45–50% participation rate of people who were invited. And then we started sort of to see fewer and fewer people participating. You know, one hypothesis that I had, because we relied a lot on letters from family physicians, and that was a very powerful thing to do 10, 15 years ago. And I think that as we have more and more team-based primary care groups, the relationship between physician and the patient is probably weaker. So receiving a letter from your family physician is not as powerful today as it was 15 years ago, where you had a lot of solo practitioners, where the link between the physician and the patient was probably much more stronger. There also might be all types of other explanations. This is just, you know, one sort of the hypothesis that we had. But we also figured that because that group would really benefit from that kind of program, we also felt that, you know, 12-week blitz is nice, but why not sort of have a more sustained program, run it for a year, and why not add sort of additional features to it? And we decided that we would have sort of monthly sessions, and we sort of added a few more things in terms of what we were doing. So more physical measures. So we would actually calculate BMI based on measurement of height and weight. We would do waist circumference. We started to integrate CAN risk. I was one of the people who developed CAN risk for PIAC. It's a sort of questionnaire-based risk assessment for development of type 2 diabetes. We have a bunch of questions, couple of physical measures, and on the basis of that, people are defined as having very high, medium, or low risk. And normally, if you have very high risk, then the recommendation is that you have sort of proper tests done to provide diagnosis. And again, the idea was that we would provide educational sessions based on what residents were interested in. So when we did our work in those 4 pilot buildings, we actually surveyed people and asked them, you know, what are sort of the things that you would like to know more about with respect to your health, to lifestyle changes, and those kinds of things. And we used that as a guide to decide what kind of additional programming we were going to bring. And then the second criteria for us was that we didn't want to sort of create brand new programs. So once we knew what people wanted, we started to go in the community and ask who has the expertise and interest to provide those kinds of educational sessions to residents of social housing. And we partnered with Quebec Society of Hypertension, Quebec Society of Diabetes, with paramedics, with community pharmacists, and we ended up with sort of a different group of people that would provide sort of those specific educational sessions on those topics. And some of them would also promote sort of the programs that they have. So public health was interested in promoting some of the programming that they have, so they would give a session and use the session to promote other programming available in the community. And of course, again, we are very much interested in taking advantage of the existing programs and initiatives and linking back to family physicians. So all the results were sent back to family physicians. So the sessions, we had a session on mental health well-being because that was one of the things that people wanted to hear. The one which was very interesting, which was given by paramedics, how to use 911, what to expect, what are the delays, what is appropriate use, inappropriate use. And we also knew that the use of 911 is fairly high in social housing, so paramedics were very interested to come and sort of give a session. So they specifically prepared a session on how to do it. One of our colleagues has a program on preparing for a visit with a family physician. And again, a lot of people go for a visit unprepared. They don't bring their medications, they don't really have their questions, they don't really know what to do, and a lot of times they forget to ask the things that they came to see the physician for. So we had sort of a nice session on how to prepare for a visit. Lots of interest in chronic pain, so we worked with one of our colleagues who is specializing in pain and really sort of looking at different self-management strategies for pain management, what people can do in order to manage their pain. Of course, we had one on healthy eating, we had one on physical activity, on hypertension. We had two local pharmacists giving a talk as to what community pharmacists can do for you in terms of different services, different recommendations, referrals, and so forth. We again trained our volunteers. So we worked with two volunteer offices. So in Quebec, a lot of volunteers are organized into regional offices. So there is one in Laval, there is one in Montérégie. So we got in touch with the local coordinating offices for volunteers, and they help us to recruit the volunteers. And the way you do that is that we would have a short article in the sort of local newspaper, and people would call, and they would sort of do the background check and all that, and then refer them to us so we could provide training. So we had sort of a training session where we would train our volunteers in terms of not just blood pressure measurement, but confidentiality, how to sort of respect people, and so forth. And in Ontario, and this is sort of something new that we started not too long ago, working with the Canadian Red Cross. So the Canadian Red Cross actually has an army of volunteers, and they are very interested in redefining their mandate, and they are getting more and more involved in health, getting more and more involved in identification of frail individuals, very much on the assumption that if there is going to be a natural disaster or pandemic, it is going to be the most vulnerable people who are going to be affected the most. So they are very interested sort of in doing those kinds of things. So we were very happy sort of to partner with them because it's a pan-Canadian organization. They have an army of volunteers. So we figured that's a nice thing to do. This is sort of some data, and here we kept it separate, of course. In the analysis, we're going to combine them, but the participation rate, it's probably a little bit lower than we expected. So this is, people attending at least one of the 10 sessions that we have offered. So each session had the educational component, but each session also had the component of remeasuring blood pressure. So in Quebec, around 33% of people participated. In Ontario, 25. Obviously, they are elderly, so 75 and 69. Again, and this is true for most of the programs that we did, females tend to participate more. I mean, part of it is age-related, but part of it, female just seem to be more interested in that type of programming. As you can see, again, the number of people with elevated blood pressure is quite high. And we would usually stratify that on the basis of diagnosed versus undiagnosed hypertension, so because we were interested in undertreated, undercontrolled versus sort of new cases. But whichever way you slice it, almost half of the people having elevated blood pressure, and again, this is blood pressure measured according to the latest guidelines. And in fact, in this project, we use even better device. It's a device from Microlife. It measures simultaneously blood pressure in both arms. So then you only use the blood pressure from the higher arm, takes 3 readings, and it does AFib detection. It's not diagnosis, but it's sort of a signal that there might be an issue in terms of irregular heartbeat.
Did you end up to select a lot of people that knew that they had high blood pressure? Do you remember?
Well, the prevalence, of course, goes with age quite a bit. So by the time people are in their 60s, it's almost 1 in half that would have hypertension. I think that the biggest challenge is probably not so much picking up new cases. It's really picking up cases which are not controlled. So, although, if you look at the Ontario results, that 10% increase in the initiation it tells us that there is still, significant minority of people in that age group that are not diagnosed. Well, so, that's a good question because, normally when you use sort of the AOBP, you actually use a different threshold. You use 135. We actually, our protocol sort of covers both systolic and diastolic. All the action is in systolic. There is nothing in diastolic, okay? So we measure that. The protocol takes into account both, but I would say that, 98% of the action is really with respect to systolic blood pressure. So we usually, when we feed this information back to family physicians, we give them both thresholds. We tell them, first of all, we give them the actual results. When we did the project in Ontario, as a family physician, you would receive a list, and it would be 2 lists that would be rank ordered by the highest systolic blood pressure. The first list would be all the patients from your practice that told us they were never diagnosed or they are not taking medication, and they would be rank ordered in terms of the highest systolic blood pressure. And the second group would be people who told us that they were diagnosed or on medication, and they would be again rank ordered in terms of from the highest to the lowest systolic blood pressure. The CAN risk is a little bit misleading. The big driver of the CAN risk is age. So once you have, the average age of 69, 75, almost inevitably everyone is classified as high risk. And yes, there was, quite a bit of obesity and everything else. And normally, using CAN risk in the sort of elderly population is probably not ideal, precisely because age is such a huge driver. I think you're getting like 10 points if you're over 65. So almost right off the bat, you're at the moderate risk. And then if you have another risk, you're classified as high risk. But, having said that, a lot of, and this is, of course, the second driver for the CAN risk, okay? So if you are overweight, obese, that also sort of adds points to your risk. Not surprisingly, the sessions were by and large received very favorably. I think that pretty much everything is over 80%. Interestingly, nobody was interested to have a session about smoking, so that's why we didn't give a session about smoking. But But you can see that chronic pain, hypertension, pharmacy services, people sort of really like to sort of get more information about those risk factors, about those services.
Do you have a list that you propose them, or they just have to come up with something?
No,
And
so
you choose on it?
so when we did the pilot in 4 buildings that not participated, we did a survey asking what people would like to know more about, and we used that as a guide, and also, really sort of taking into account a little bit of what's available. We didn't want to start sort of creating educational sessions from scratch that, once we are gone, nobody would be willing to provide. So that was sort of our justification. And we were a little bit worried about doing mental health. It was a lot of interest about sort of depression, anxiety, and all that, because we were sort of not quite sure in terms of what we could really offer. But then we were sort of quite comfortable with the session that was prepared. All the sessions were at fairly low literacy level. They were very practical. They were really sort of about telling people practical things that they could do, or sort of existing resources and programs that they could access if they felt that that was not sufficient for them.
It would be interesting to have a qualitative study. I guess you were primarily quantitative in your...
No, so actually...
to try to understand why smoking, for example, is such an important risk factor.
So the prevalence of smoking, because we looked at the prevalence of smoking, was only around 5%. So not very high. By the time people are in their 60s and 70s, even in Quebec, the smoking rates tend to be much lower. And that probably explains part of the reason why there is no interest. There was more interest around secondhand smoke, but a lot of that is done through administrative measures where people are basically prohibited from smoking in their apartments. So, but that's sort of how it was dealt with. So I think that part of it is that by the time you are in your 60s and 70s, you really have just hardcore smokers left, and they have no interest to hear about it. It's a very small proportion, so you're probably wasting your resources chasing after those individuals. And I've seen that before, it's like you have to pick your battles, okay? It's yes, we know it's a risk factor, but if nobody wants to hear about it, there's not much you can do about it. So in terms of our results, well, we expect I actually don't have results because they're not available yet, because our design is comparison of 1 year prior. We look at 1 year during the intervention and 1 year post-intervention. So basically, we finish our intervention in the fall of 2019. So we have to wait another 9 months or so before we can get sort of the after data, because we expect that some of the changes would have taken place during the program, but some of the changes take a little bit longer. If people start treatment, if they make lifestyle changes and so forth, it's going to take a little bit more time. And also you have to keep in mind that people could have participated in the program at the beginning, in the middle, or at the end. Some people participated throughout, but this is sort of really to allow for what's going to happen. And we're doing economic analysis, and it's going to be sort of fairly standard analysis in terms of looking at impact of the program.
So is the population in these housing, is it stable?
Yes, it is. So this is, another thing that, and I'm not explaining here everything. So some of the secondary outcomes is transfers to long-term facilities. And there are really 3 reasons why people move. One is that they are transferred to sort of higher level of care because there is no health services offered there. There might be a nurse, there are a couple of social workers, but this is not sort of a nursing home. So transfers to long-term facilities, death, people die. And very few people move because, especially in the context of rent controls and those kinds of things. But we actually do have our denominators for each year in terms of exactly how many people moved and what was the reason. And our secondary outcome, of course, is mortality and transfers to a long-term facility.
So, really interesting results. I'm sorry to take up your time, but with regards to other studies looking at these sort of community-based interventions, there have been quite a lot of heterogeneous results.
Mm-hmm.
There was a study in the New England about like a healthcare hotspotting, where teams would
Mhm.
this was done in New Jersey, in sort of similar
Mhm.
lower income settings, and there was a neutral trial where they couldn't show any benefit of having sort of nurses, social workers, all these people going out to the community.
Mhm.
So any thoughts as to why we're seeing such heterogeneous results? Like your initial results were very
Yeah.
positive. What do you think is going on there?
Yeah. Well, I think there is, a couple of things going on. I think that one thing is that, whenever you're sort of trying to do a population level sort of intervention, the biggest issue is, how strong is the intervention and what is the uptake of the intervention. So it's not unusual for those population-based interventions to have, maybe 2 or 3% participation rate. So hoping that this is going to sort of to translate into, meaningful decreases at the population level is a little bit unrealistic. Once you get, 25, 30% of the people participating, it's not unreasonable sort of to expect that you're going to see some impact. And, we also suspect that there might be several different mechanisms going on. And we've done some qualitative studies, and some of them are quite fascinating as well. But some of it is probably people perhaps adhering more to their therapy. Some of it might be people taking on and actually making lifestyle changes. Some of it might be initiation or titration of therapy by their family physicians. And there is probably also sort of synergies between those and sort of the group effect. So there might be, different mechanisms. We were always quite comfortable saying that, we don't really care what's in the black box because everything is inexpensive, it's easy to deliver. So why sort of worry too much about which of those, things was responsible for it? And as I suspect that it's probably fairly sort of synergistic, that all those things play a role.
That's always a problem of all these multi-component
Mhm.
intervention, even the medical one.
Mhm.
This one is population-based.
Mhm.
For
Mhm.
all these approach.
Yeah. Yeah.
What are you really changing? Because you're assessing the ultimate outcome, but
Mm.
it's
Yeah.
what you're trying.
So the qualitative analysis that we did was really interesting. We had a postdoc working with me, and she did social network analysis. So she actually went to 2 of the buildings and administered surveys and talked to people. And she did social network analysis as sort of potential explanation why participation was lower and higher in certain buildings, and really looking at who are sort of the unofficial opinion leaders within the buildings and what are some of the cliques that exist in a building and how that impacts on the sort of interactions. It was a fascinating work because it's like a mini society. You have 60 or 70 individuals, and you have sort of groups and subgroups, and all that influences very much how the buildings function. And some buildings were clearly dysfunctional. Like some buildings had, all the buildings in Quebec had community rooms. So basically a room of this size where people could like bingo, and they had sort of different activities and that. And this is where we were sort of delivering those sessions. But some of them had committee of tenants, which were fairly active, and they were, animating a variety of activities and so forth. Some other building, there was nothing like that. So, and those are almost like adjacent buildings, a couple of streets away, and very different dynamics, very different ways in terms of how they were structured. So there's a lot of sort of interesting things to learn in terms of how do you engage residents, and how you have to sort of understand some of the power structures within each building.
I have another question. So this is very interesting. Have you looked at other outcomes that would not be cardiovascular in nature? So I'm interested in falls and fractures. So for example, so if you were to, I would expect maybe we would see an improvement in maybe in
Yeah.
fractures as well.
Yeah, so we actually, again, because we work with administrative data, our ask is considerably bigger in terms of the data that we're going to get. There are limitations associated with administrative databases. So, if the fall resulted in the visit to the emergency department or hospitalization, and if it was coded as such, then we have it. But if someone, fell and got a big bruise, obviously we're not going to know about it.
You could capture fractures pretty easily, and in that age group, serious falls, which
Mhm.
would be what you're interested in, would be resulting
Yeah.
in
Yeah. So
Because I'm interested because, exercise and being aware more of your health behaviors might improve
yeah,
not only
yeah.
cardiovascular outcomes,
Oh,
but other
absolutely.
outcomes. And then if you could show that,
Mm.
it's
Yeah, so one of the reasons we didn't give a session on fall prevention because there is a fairly active program that was offered to all those buildings already. So again, we didn't want sort of to duplicate, and of course it would also have an impact on the control buildings. So the idea in terms of selecting which programs we're going to offer was also driven what's available. And in Montérégie there is I think it's a provincial program of fall prevention, and all the buildings have already participated in the program. So we felt it would be redundant on our part to offer it, and also that the likelihood that we could sort of do better in the intervention buildings than control buildings would be fairly minimal.
no, you might be able to actually.
Mm-hmm.
That's what I'm saying is that what I'm thinking is that in general, if people's health is better, they tend to fall less.
Mm-hmm.
And so even just to look at the numbers of fractures, you might be able to see
Mhm.
fractures kind of a high
Yeah.
percentage.
But sort of the beauty of working with the admin data. So for that RCT that we did in Ontario, we just published last year a 5-year follow-up, because you can follow up people over time, so you can see what happens 5 years later. Is there still the impact of the program? Is there still sort of a difference in terms of what's
Do you
happening?
have a buy-in by the government? Where is sort of the next step?
I think that
Everyone is claiming that the real-world evidence data are needed. When you get to that, this is probably the best you can do, okay, with those
Yeah.
pragmatic trials.
Yeah, I have to say that I'm sort of pretty much sort of giving up on this sort of idea that evidence influences policies. We tried everything under the sink.
And I'm not we've been working, a lot of people work with evidence for at least the last 20 years,
Yeah.
and showing how effective and cost effective even it can be, and it's usually not what is driven the change. Okay?
It's extremely frustrating. So we've done economic analysis. The economic analysis demonstrated that each dollar that you spend on this program saves $2 in admissions to hospital. So, it's not through the roof, but it's not bad, okay? It's like, you put $1, you're saving two. That should be of interest. Not really.
So we seem to have the same experience.
Yeah, it's
It is very frustrating, okay, and because this is the best you can be in terms of
yeah.
also involving the community where okay, this should be interesting at the time where it's clear that the resource will not be able
Yeah.
to follow the need from the medical need, and having these initiatives where it's not only people are very much into the shared decision approach, but many have failed because whatever you share may not be evidence-based or based on something that can really have an impact. Okay, and what you're using here, you're using the chronic care model, which has evidence-based. Okay, you let people choose, but you also introduce really what is needed to impact on these health outcomes.
Yeah.
Okay, and
Yeah.
it's,
But I think pretty much all the projects that we did, and we have some ongoing projects. We have a project in the Philippines that we are doing, which is also very well received. We did a randomized trial in Philippines. They gave us 5 more years of funding to scale it up for the full province. Everything is driven by research dollars. The moment you don't bring a research grant, everything stops, and there is no uptake, no interest. We are a country of perpetual pilot projects. It's frustrating.
are you
Yeah,
That's okay. That's because
yeah, I'm done.
You
Yeah.
want to conclude?
Yeah, well, I'm sort of like, and I guess.
Talk all afternoon.
I think that a lot of us are struggling with the same issue because, it used to be that our role as researchers was to generate evidence, okay? So we've been doing that. Then you were told, well, now you have to involve decision makers as part of your research protocol because that's going to accelerate the uptake. So, like everybody else, we did because that's what CIHR was asking for. Then they told us, well, you have to include patient preferences, okay? So we did. So, you keep on sort of doing those things.
Now you have to be elected.
That's right. So it is sort of very frustrating, and we've done, I think, 4 projects in Laval. So we implemented this program in Groupe de Médecins de Famille. We implemented this program for people who are on the GACO list, waiting for a family physician. We implemented this program as part of Ciblé Santé, which was sort of the Laval-wide program around cardiometabolic disease. I think all of them showed, they were not randomized trials, they were really implementations. All of them showed that we could mobilize the community, that we could train volunteers, that we could get, 15, 20, 25% of target population participating in the program. The moment we were not paying to sort of do the program disappeared.
Yeah.
So, that's a little bit frustrating. So that's it.